Welcome back to CE Solutions. My name is Caleb Frady. I'm a paramedic in North Carolina, and today's lesson we're going to cover facial trauma. Our objectives for today's lesson include identifying the prevalence and common causes of facial injuries, reviewing the anatomical structures of the face, eyes, ears, mouth, and neck as they relate to facial trauma, illustrate facial injuries that EMS providers are faced with in the field, and lastly, describe the assessment and management of injuries to the face and neck. Facial trauma is a very common presentation across the globe. A research study published in 2020 that took data from 2017 found that globally there was over 7,500,000 cases of facial injuries reported that year. The most common causes that this study highlighted included falls as the most common cause of facial injuries, physical violence or assaults, exposure to mechanical forces, so that would be something getting hit in the face with a baseball bat or another blunt object, and also noted motor vehicle crashes as a common cause of facial trauma, with falls again being the leading cause of facial trauma globally. If we look at this incident map from the same research study that I just noted, we can see that in the United States is an orange color. And according to the graph here, that means that the United States in the year of 2017, when this study took data from, reported between 100,000 and 1 million cases of facial trauma. That makes this an extremely common presentation that pre-hospital providers will encounter that has a varying range of severity.
Facial trauma can present with minor symptoms that are not life-threatening, but may be distracting to providers in the setting of patients that may have multiple facial lacerations, causing what looks like a lot of bleeding, but in the initial moments is not life-threatening. It can be as severe as what you see on your screen here, where a patient has severe facial trauma from a chainsaw that is going to require constant management of this patient's airway throughout the encounter. Facial trauma also presents with occult or less noticeable injuries, and this can present a complication for providers when assessing facial trauma, as it makes it difficult to truly appreciate the level of underlying severe injury. When looking at the case on our screen here, we have a patient who was involved in a fist fight, and that can present a wide variety of possible injuries from minor and non life threatening to very serious and even life threatening. The swelling and edema from this injury can be masking some of those underlying injuries like a zygomatic fracture or an orbital blowout fracture that we'll discuss as we move through this lecture. So the most important thing to note from this image is that we should always contrast the patient's presentation and injuries that we assess with the mechanism of injury that was applied.
Before we move into discussing specific facial injuries and presentations, it's important to have a short review of the relevant anatomy for facial trauma.
Our skull is comprised of 14 bones that not only provide shape for our face, but also serve as various attachment points for ligaments and tendons so that muscles can provide facial movements and jaw movements and other necessities for life. It also provides protection to the organs that lie underneath, such as the brain. Some of the major bones that, as providers, we should be aware of so that when we are assessing and performing a physical assessment of facial trauma, we can appreciate what bones could possibly be fractured are the ones you see on the screen here. The frontal bone is highlighted in blue. Our nasal bone, just underneath our nose, is a common fracture point. Our cheeks are made up of the zygomatic bone on either side, and our temporal bone lies just underneath the ears. Looking at our jaw in pink, you can see the upper part is called the maxilla, and our lower jaw is referred to as the mandible. Now, the mandible is the only movable bone of this facial anatomy that you see on your screen. And all of this is important so that we can appreciate what bones have the potential for fracture during our physical assessment. Our eyes are a very complex organ that rely on several different processes to be able to receive light and interpret that as vision so that we're able to see and interact with our environment. And I think you all would agree that losing the ability to see would make daily tasks significantly more difficult. So when we refer to trauma of the eye, that's a true emergency when we do have vision changes, as that can severely affect a patient's quality of life. Looking at the anatomy of the eye, you can see from the interior view where the eyelids are, that's the weakest portion of the eye where there's not as much protection, and the eye is very vulnerable to direct trauma from the anterior or frontal plane. Some other things to take note of. The globe or the eyeball itself is filled with a jelly-like substance, and that substance really just helps to provide a little bit of cushion and also help control some of the pressures within the eye. And then at the back of the eye is where the optic nerve and the eye's blood supply come in. Controlling movement of our eye is going to be extraocular muscles that are attached. Those are going to be innervated by cranial nerves, controlling those movements. The pupil constriction and dilation is controlled by parasympathetic nerve fibers. And then some other important things to take note of from this image here is our eye is surrounded by orbital bones, and underneath those orbital bones is a fat layer, subcutaneous tissue that helps to further cushion the eyeball. That can make the eye susceptible to a blowout fracture if pressures within the orbit of the eye are increased very drastically. It can cause those contents to be pushed out in between those orbital bones. The ear is composed of three different levels. Beginning with the inner ear, this is where the more advanced auditory processing centers are located. There's also areas of the inner ear that are responsible for balance, spatial awareness, and sense of direction. Regarding facial trauma, the inner ear is not as applicable because there's really not a way to assess for injuries of the inner ear secondary to trauma, aside from a patient who may have a complaint of vertigo or hearing changes. Moving into the middle ear, this is where the tympanic membrane is located, which is susceptible to trauma, especially barotrauma, where it can rupture and create several different symptoms that we can assess for in the field, such as ringing in the ears or even blood and fluids coming from the ear itself. The outer ear is most applicable to facial trauma, as we are able to see and assess the structures of the outer ear, in addition to being able to see injuries to the ear. It's composed of the pinna at the top of our ear, and the earlobe is the structure down at the bottom. The ear canal enters from the outer ear into the middle ear. The biggest thing to consider with the ear canal is that it is narrowed and can be angled in some patients and really varies from person to person. Pay attention to where the temporal bone lies, where it's just behind the ear itself. Injuries to the ear can look gruesome and be distracting, especially if an ear is partially avulsed or completely avulsed. That can be considered a distracting injury. The largest consideration regarding anatomy of the mouth and facial trauma is understanding that, for one, the structures of the mouth are highly vascular and can bleed quite a bit, but also that the proximity of these structures to the trachea means there's an increased chance of airway occlusion with injuries of the mouth. For example, teeth can become dislodged and present as a foreign body airway occlusion. Altered mental status patients can lose the ability to protect their airway, and their tongue can simply close the airway and prevent a patient from being able to breathe. And even the highly vascular nature of these tissues, when they are lacerated, bleeding leaking back into the oropharynx can increase the risk of aspiration. The neck is considered a junctional region, and it's home to some very important structures that are mandatory for life. The protection of those important structures is not as robust as other areas of the face, for example, the brain that's protected by the skull and our facial bones. The neck's protection is really the different muscles that allow for movement of our neck to be able to look around. Those muscles are also highly vascular and can bleed quite a bit when injured. Some of the important structures that move through the neck include the spinal cord. That's the source of connection between our brain and the rest of our body. The trachea, which connects the upper airway with the lower airway, allowing for effective breathing. And then the major blood vessels that move through the neck, such as the carotid arteries, which is taking blood to the brain, and our jugular veins, which are returning blood back to the heart. Our external jugular veins are very large veins that are more anterior to the skin and are more susceptible to laceration from trauma.
Soft tissue injuries are rarely life threatening, but in the presence of a significant mechanism of injury, they have the potential to mask or hide severe underlying injuries. They can also be considered distracting injuries, whereas multiple small lacerations to the face and scalp can bleed a good amount, but in the initial moments, that bleeding is not life threatening. The swelling and edema that follows soft tissue injuries to the face also contributes to hiding underlying facial fractures and our ability to assess the severity of the patient's injuries. The different types of soft tissue injuries include closed injuries, which Mija et al. Reports often indicates a more severe underlying injury. Lacerations, abrasions, and avulsions are also included, and impaled objects. With impaled objects, they have an increased potential to create airway compromise depending on their location. Soft tissue injuries and facial fractures often go hand in hand, whereas when one is present, the other is likely present. Soft tissue injuries are hiding some of the facial fractures and inhibiting our ability to find them, aside from us having a higher index of suspicion that one is present. Ecchymosis or bruising is often the first sign that appears from a facial fracture, but obviously that takes some time to develop. So just after injury, the only thing that we may see from a visual inspection is slight reddening of the skin. So we should maintain that high index of suspicion with any type of trauma to the face. Some other general signs of a facial fracture include pain over a bone or pain to palpation during our physical assessment, feeling crepitus where the bone ends are rubbing against one another during the assessment, visualizing and seeing deformity or asymmetry when looking at someone's face. Something that can help with assessing that is utilizing friends and family members on scene if you have that ability to see if they notice anything different about the patient's face that may be able to help you pick out some subtle clues that could indicate a facial fracture. Impaired ocular movements. So when you are dealing with fractures around the orbits of the eyes or the cheekbones, that can involve some of the extraocular muscles. So a patient being unable to move their eyes in certain directions can indicate a facial fracture in that area. And patients reporting visual changes secondary to facial trauma is another clue that there may be a fracture underneath the soft tissue trauma. A fracture of the nasal bone or a nasal fracture can be a common presentation when assessing for facial trauma, as the nose is fairly exposed on the front of someone's face. It's a very painful injury that can come with bleeding externally and internally into the oropharynx, and that's really a concern with any type of facial injury, especially as you start to get towards the lower third of the face, is that fracture lacerating major vessels that then cause uncontrolled bleeding into the back of the throat. And if you have that in conjunction with a patient who has an altered mental status, then as a provider, we know that we have a serious problem that requires immediate intervention. A nasal fracture is most easily identified by lateral displacement of the nose, which is what you see in the image here, where the nasal bone is very clearly deformed and angulated laterally, would be a positive indicator of a nasal fracture. A fracture of the mandible results from direct trauma to the lower third of the face or to the lower jaw. And because of the shape of the mandible and the force required to fracture this bone, you can notice or locate more than one fracture across the mandible itself. Some things that are associated with a mandible fracture or some clinical clues to look out for include misalignment of the teeth, a patient complaining of numbness around their jaw or specifically their chin as there's nerve involvement preventing the sensation to that area. A patient reporting the inability to open their mouth as the joint, if the joint is dislocated, it's fixed in place and unable to move. And also noticing swelling and bruising around the lower part of the jaw itself.
Le Fort fractures are maxillary fractures, and they're associated with massive facial trauma. Essentially, what's happening is areas of the face are being separated from other areas. Typically, the lower half is separated from the upper half. There's four types of Le Fort fractures that we've identified. The first is going to be our type 1. In a type 1 Le Fort fracture, this is going to involve the hard palate and the upper area of the maxilla here, where that's where the fracture is, separating that area from the rest of the skull. Next, we have our type 2 Le Fort fracture, type 2 here. And in type 2, we see a pyramid-like shape that involves the nasal bone and the inferior maxilla. So a type 2 Le Fort fracture would have kind of like a pyramidal look shape here that involves the nasal bone and the upper portion of your maxilla here. So it can kind of come down into this region here. A type 3 Le Fort fracture begins to involve midfacial bones separating the entire midface from the cranium. So that would include a fracture that is involving the zygomatic bones here and really all of these midface bones here. Um, all of this would could be classified as a Le Fort fracture, where it's separating this part of the face from the upper area of the face. A type 4, a type 4 Le Fort fracture is the same as a type 3, except in a type 4, you just start to have involvement of the frontal bone here, and that's what would make it a type 4 Le Fort fracture. Le Fort fractures will present with severe pain for our patients. You may note anesthesia, numbness, tingling, loss of sensation to the upper lip area where the maxilla has been separated from the rest of the face. Higher level Le Fort fractures that involve the cheekbones up into the frontal bone can include visual disturbances. You may have hemorrhage into the eyes, some subconjunctival hemorrhage. Facial deformities, swelling, and edema can also be noted. And also look for cerebrospinal fluid leaking from the nose or ears, as these injuries require a lot of force to break the maxilla, the nasal bone, the zygomatic bones. All that force that's required really gives you a high index of suspicion for underlying injuries. Another clinical finding of a Le Fort fracture, because it's essentially separating the face from itself, when you assess the patient's maxilla, sometimes you can see that deformity. If you look at this injury here, you can see how the maxilla, where the teeth are, is hanging much lower than it should be. And that's because that section is essentially free floating now and it's not attached to the upper facial bones anymore. So that would be a clinical finding you would see with a Le Fort fracture. Orbital blowout fractures involve the bones of the orbital floor and typically result from an object striking the eye and its surrounding soft tissues. This mechanism creates a sudden increase in pressure inside the orbit, which causes a fracture at its weakest point, and that's usually the orbital floor. Now, the eye itself is generally protected um, inside the globe or the eyeball itself. It's the thin bones that make up the orbit of the eye and the fatty tissue that cushions it that escape through the open fracture in the orbital floor. The presentation of an orbital fracture can include double vision if the eye is involved, as the eye can retract back into the space created by the fracture, and that can cause damage to the globe. You may see decreased sensation over the eyeball or around the cheek, and that would indicate associated nerve damage. A patient may report, or you may note on assessment, paralysis of an upward gaze, where the patient's going to be unable to follow your finger above midline. Most orbital fractures are able to be managed in the ED, and the patient can be discharged to a specialist. However, there may be some cases if there is acute vision changes that do require emergency management um, at a trauma facility. This is a good opportunity to talk about zygomatic fractures over the cheekbone. It's a pretty strong bone that takes a lot of force to break, so that just gives you a higher index of suspicion for serious injury. This can cause the patient's face to appear flattened and can also lead to loss of sensation and paralysis of an upward gaze as some of those extraocular muscles and nerves become involved with the fracture itself.
Injuries to the eye include laceration of the eyelids. Now, the eyelids perform a pretty special function, and that's going to require a specialist intervention to repair those types of lacerations. The largest concern is when controlling bleeding to this area of the face, to be cautious of the amount of direct pressure that you utilize, as too much direct pressure can compress some of the structures of the globe, and that can lead to vision impairment, essentially from squeezing those important structures. The eye is also vulnerable to small objects entering it and landing on the surface. Dust, small pieces of wood, small metal shavings, etc. And this is going to lead to irritation and inflammation of the conjunctiva. A corneal abrasion would occur secondary to excessive rubbing as a result of the irritation and inflammation. Most of these small objects are able to be flushed out with water, normal saline, sterile water, etc. The big concern is with metallic objects, as they can create a rust ring inside the eye after just a few hours of the object being lodged. So anytime you have a patient that has had a metal object in their eye, we should assess for this rust ring and definitely refer this patient to for evaluation due to that. The eye is also vulnerable to blunt eye trauma, and the severity from blunt eye trauma varies pretty greatly. It could be direct trauma and swelling and bruising to soft tissues around the eye, or a more severe, those injuries associated with rupture of the globe and associated vision impairment. A hyphema is one of the injuries that we can see from blunt eye trauma, and it's bleeding into the anterior chamber of the eye and is a true sight-threatening emergency. To identify a hyphema, a provider can shine a light into the patient's eye, and this will help us differentiate bleeding into the anterior chamber of the eye compared to bleeding on the corneal surface. And you can see that really well in the image on your screen, where you can see the bleeding is actually occurring in the eye itself and not just on the surface. Another major concern with blunt eye trauma is retinal detachment. As the retina detaches, it takes its blood supply with it, and that leads to tissue death and vision changes. This is a common injury that can be seen in sports, such as boxing, and it presents as a painless condition where the patient may report vision changes, such as specks, floaters, or flashing lights in their field of vision. Thermal burns to the eye are usually limited to the eyelids as we close them as a reflex to protect the globe of our eye. With eye injuries, chemical burns are a greater concern. And there's generally really two types of chemicals that cause burns here is acids and alkaline solutions. Acids tend to cause immediate damage to the cornea, making them appear white and opaque. But after the initial damage, there's not as much further damage that's noted because our body's able to produce tears that prevent further penetration of the acid into different structures of the eye. With alkaline solutions, they're not as easily neutralized by our body's tears, and as long as they're making contact and not flushed out, they're penetrating deeper into the eye, damaging all the tissues that they touch. And this can lead to more severe uh, consequences, such as emulsification and necrosis of the eye. With any burn process, whether it's chemical or thermal, our main goal is to stop the burning process. The outer ear is also vulnerable to trauma. It can be lacerated partially or completely avulsed. A foreign body can be stuck in the ear. And injuries that require EMS treatment typically occur to the outer ear. Other injuries of the ear to be aware of include a ruptured eardrum that can occur secondary to direct blow to the ear, or pressure related injuries such as diving incidences or loud noises such as gunfire explosions. The presentation of a ruptured eardrum would include hearing loss and bloody drainage. It's a painful injury, but it's usually self limiting and can heal without any major complications. Regarding oral and dental injuries, bleeding from the soft tissues within the airway can impair the airway the same way that an avulsed tooth would become an airway obstruction. Mouth injuries are the result of blunt trauma to the face or penetrating trauma, such as a gunshot wound, a laceration, or a puncture. Our main priority when assessing patients with oral and dental injuries is protecting the airway against aspiration, as that severe bleeding can make it very difficult for a patient to control their airway secretions, leaving them to pull in the back of the oropharynx, increasing the risks of aspiration. Additionally, that patient is to protect the airway, that patient's going to start to swallow the blood. And blood is a gastric irritant. So as they swallow more and more blood, the chances of them vomiting that blood back up increase, and that further increases the risk of aspiration. So that's our biggest concern with oral and dental injuries is protecting against aspiration. As we discussed in anatomy, the neck is an extremely vulnerable location on our body, as it's home to really important airway structures, blood vessels, and our spinal cord. So, any injury that we have to a patient's neck, we should have a high index of suspicion and consider that injury to be critical until we can prove it to be otherwise. The neck is vulnerable to blunt injuries from direct trauma to the neck or hanging, causing trauma to those major structures. Closed neck injuries have a higher potential of leading to airway compromise secondary to the trauma, as swelling and edema within the neck can compress the airway structures, or the trachea itself can be affected, limiting a patient's ability to ventilate for themselves. Penetrating wounds to the neck are secondary to mechanism of injuries such as gunshot wounds, stabbings, impaled objects. They can be superficial and only involve the fatty tissue around the neck, or deep and involve the underlying structures of the neck. The primary concern with a deep neck injury is massive hemorrhage and airway compromise from the soft tissue swelling or drainage from the airway structures into the airway structures themselves. A special concern with massive hemorrhage from the neck is an air embolism. Your external jugular vein has the ability to suck in 10% of your tidal volume, creating a pretty large air embolus that's would then travel to the heart and end up lodged somewhere within the body. Impaled objects are a special concern. As providers, if we have an impaled object in a patient's neck, our goal with assessment management is to stabilize that object in place unless it's interfering with our ability to ventilate and control a patient's airway. Direct injuries to the trachea and esophagus themselves are not as easily identifiable as other more obvious injuries. Some symptoms of direct trauma to the trachea would include stridor, hoarseness, swelling, edema, deformity, and a finding known as subcutaneous emphysema, which is when air is making its way into the subcutaneous tissue layer, and it looks like the air is bubbling up as that air is filling up that subcu layer. Next, let's move into the assessment and management of facial trauma. Now that we've covered the major types of injuries that we're faced with as pre-hospital providers. Facial trauma has a high probability of injuring underlying organs. And because of that, we should maintain a higher level of suspicion with these types of injuries. We should also train ourselves to not be distracted by obvious facial injuries and neglect an unseen life threat. This could be as simple as a patient that has multiple small lacerations to their face, but also has internal hemorrhage into their chest or belly. That as a provider, if we spend too much time on scene trying to stop minor sources of bleeding to a patient's face, then we've neglected a major underlying injury to another area of the body. So it doesn't just apply to the underlying organs of the face itself. During the primary assessment, be sure to look inside the airway and assess the patient's ability to protect their airway. As providers, we may need to immediately intervene to control the patency and protection of our patient's airway. Most facial trauma injuries have the probability and the potential to obstruct the airway through really several different mechanisms. It could be the tongue that is occluding the airway and airway positioning is needed. Could be bleeding into the oropharynx. Could be teeth or other structures that have been dislodged and are now occluding the airway. So be sure to do a very good assessment of the airway in facial trauma. Should also not neglect the need for cervical stabilization. Any amount of major energy that's applied to a patient's face has the potential to damage the cervical spine, and that should absolutely be incorporated in our assessment and a concern of ours to maintain inline spinal stabilization. Before moving out of your primary assessment, be sure that you have intervened and are managing any and all immediate life threats your patients may have. As we move out of our primary assessment and are managing any present life threats, we can transition into a physical trauma exam. Generally speaking, this trauma exam is best served starting at a patient's head and working down towards the feet. So, when starting at the patient's head, the first step is really to inspect and palpate and look at all the different areas of this patient's face on the front and back. Assess for drainage coming from the ears and nose. There could be clear fluid. You may see what's called a halo sign if you have blood coming from the ears. If you put a piece of 4x4 gauze up against the ear, and when you look at it, if there's a yellowish fluid around the blood, that's a positive test for cerebral spinal fluid, which means that bleeding is coming from the brain. If you do have drainage from the ears or nose, and you have other symptoms associated with an underlying head injury, that's not bleeding that we would attempt to stop in the field, as that bleeding is a way for the body to release some of the pressure that's building up inside the cranial vault. Two other clinical findings we should be on the lookout for are raccoon eyes, which is bruising just underneath a patient's eyes, and battle sign. Battle sign is bruising that occurs just behind the ear. Both of those are positive indicators of a basilar skull fracture. We should look for other signs such as facial symmetry, deformities, and swellings, and take note of any abnormalities that we come across. Look and take note of any lacerations or avulsions that you come across, and when appropriate, manage those injuries. This is a good opportunity to look in the airway once more and make sure you haven't missed anything. Assess the patient's pupils, assess their gaze and their extraocular movements, assess peripheral vision and their ability to follow your finger with their eyes. All those are good indicators that can help you rule out any type of injury to the eye itself. As you continue to palpate a patient's face, be sure to palpate all of the facial bones, the frontal bone, the zygomatic bone, the maxilla, the mandible, assessing for any underlying crepitus, tenderness, or deformity. As you move to the patient's neck, look out for jugular venous distension and any other open injuries that you may find to the neck. If you do encounter an open neck injury, that would be something that you would want to go ahead and address immediately to prevent against an air embolism. And lastly, assess movement and sensation of the patient's face. Emergency medical care of facial trauma. The first step is to protect the patient's airway with patient positioning. A responsive patient that has bleeding into the oropharynx can be placed in a seated position that allows blood to drain out of their airway instead of back into the oropharynx. Otherwise, a jaw thrust to open the airway and suction are indicated. Suction for no longer than 15 seconds and follow that with 2 minutes of ventilation. Remove any teeth fragments you see as you are assessing the airway, only if you can see them. As providers, your agencies may allow you to use McGill forceps to remove those items from the mouth. Our goal should be to maintain an SpO2 at 94% and be prepared to ventilate anytime we have a patient that has inadequate tidal volume. Only consider removing an impaled object if it interferes with the airway. For example, you have an impaled object through a patient's cheek and you need to ventilate for them. Removing the impaled object is feasible. In that case, after you have removed the object, place gauze padding inside the mouth and outside of the cheek, providing counter pressure against each other to control the bleeding from that object. When managing eye injuries, utilize gentle pressure to control bleeding and cover both eyes. What this does is this prevents sympathetic eye movement. So when one eye is injured, the other eye is going to try to compensate and move with the injured eye. That can make the injury more painful and even cause more damage. So cover both eyes when you have a direct eye injury. In some cases, elevating the patient's head 40 degrees is beneficial. This would be in the case of a patient with a hyphema, as elevating the head can assist in controlling the intraocular pressure until evaluation. This would also be used in consideration with your suspicion of a cervical injury and may not be a feasible intervention in the field. If you have an eye that is avulsed or out of its socket, apply a moist, sterile dressing and provide transport. Do not try to manipulate or put the eye back into the socket. If a foreign object is impaled into the patient's eye, do not remove it and stabilize it in place with bulky dressings. In some cases, a styrofoam cup can be used to stabilize a longer object that's impaled in the eye, and then utilize gauze circumferentially wrapped around the patient's head to hold that in place. With stabilizing impaled objects, the best advice that I have is you're going to need to be creative in how you do so. And at the end of the day, as long as the object's not moving a gross amount, then you're successful in that intervention. When irrigating a patient's eye, be sure that you do so from the nose out so that the particle or chemicals that you're trying to wash out flow away from the patient's eyes and not back in to the eye or across to the other eye. Do so continuously for at least 5 minutes. Alkaline substances may require longer irrigation times, up to 20 minutes. There's several different ways that we can flush a patient's eye out. This could be an eye wash station that may be near where the incident occurred. It could be sterile water that we pour into a patient's eye for 5 to 20 minutes. Or it could be what's commonly done in the field is a bag of IV fluids attached to a nasal cannula. You just simply push the IV tubing into the O2 port of the nasal cannula and run the IV bag, and it'll come out the nasal prongs. You can then put the nasal prongs on the patient's face, and that will cause the fluid to run from the nose out. To control bleeding from an ear injury or an avulsed ear, place padded dressing between the ear and the scalp, and then secure that with rolled gauze. That's going to help provide direct pressure to the ear itself without causing any damage to the scalp. If the ear is partially or completely avulsed, it is good practice to realign and bandage that in the normal position. Be sure not to probe into a patient's ear or attempt to remove any foreign bodies from the ear, as the ear canal is narrow and angled, and we can cause more damage by doing that. The best practices of managing neck injuries. Open neck wounds like lacerations and punctures should ultimately be covered with an occlusive dressing to prevent against an air embolism. To control bleeding, Apply direct pressure with a bulky dressing, but be sure to only apply direct pressure to one side of the neck and monitor the patient closely for any signs of decreased perfusion to the brain. Hemostatic gauze has a high success rate in the pre-hospital environment at 90.5%, and it should be utilized when we have massive bleeding from a patient's neck. When wrapping wounds of the neck, be sure to never circumferentially wrap gauze around a patient's neck. Instead, start on the injured side, wrap the gauze around the opposite armpit, and then back around. That keeps this side of the neck or the side opposite to the injury open so blood flow can be unobstructed to the brain and back to the heart. Neck injuries are one of the most difficult injuries for providers to manage in the field. And Simpson et al. Identified that there's not a clear cut consensus regarding the best practice in management of penetrating neck injuries. So, what they did is they conducted a study where they got together subject matter experts, so EMTs and paramedics, and basically determined what the best practice or the commonality in management was between this group of experts. And what they found was that direct pressure, along with wound packing with hemostatic gauze where possible, is a mainstay of treatment for catastrophic hemorrhage within the junction of the neck. So, what this means for us is that in places and areas of the neck junctional region, wound packing is feasible as a life saving measure to stop massive hemorrhage. And when it says where possible, that's just an understanding as providers that the neck also has airway structures that run through it. So when performing wound packing in the neck, we should be positive that we're not compressing the airway structures and we're not compressing both sides of the neck and monitor the patient very closely. Wound packing is a skill that your medical director may or may not allow providers to do. So please follow your local protocol and medical direction for this procedure. Thank you for taking the time to watch this lesson on facial trauma. We've covered the prevalence of facial trauma globally and within the United States, with falls being the most common cause. We've looked at anatomy that's relevant to facial trauma and discussed and presented some of the common injury presentations that we see as providers. And we have ended with our assessment and specific management of injuries that we may face in the field. Thank you again for watching. See you next time.